Hello, my name is Jay. I'm a fourth year pathology resident, and I go over cases almost on the daily from head to toe. Today we're doing something different. We're going to do microbiology, which falls under clinical pathology. So this is from University of Pittsburgh and unknown cases. So let's go over this one. A woman in her 50s with right ear pain contributed by Dr. Jerome and William Pascal. So this is a woman in her 50s, presented to her PCP with several days of right ear pain, so maybe otitis media or something. She was afebrile with stable vital signs and denied any headache, neck pain, or nuchal rigidity. So less likely she's septic from this. Otoscopic exam revealed erythema and bulging of the tympanic membrane. She was diagnosed with acute otitis media and prescribed azithromycin. One day later, the patient presented to the ED with severe headache and neck pain. Somnolence and expressive aphasia. She was febrile and demonstrated nuchal rigidity on physical exam, so maybe meningitis from this bacteria from acute otitis media. Labs were notable for leukocytosis 17.6 with left shift. Chest x-ray showed no evidence of acute process, and UA was unremarkable, so less likely pneumonia or a UTI. Stroke workup was pursued and was unremarkable. Given concerns for meningitis, LP was performed and showed turbid CSF with elevated protein, glucose 65, elevated white blood cells. So probably a bacterial infection. A gram stain of the CSF showed moderate white blood cells but no organisms. Empiric treatment for meningitis was initiated, include vanc, ceftriaxone, and acyclovir to rule out herpes. Bacterial culture of the CSF on this this chocolate agar grew pale gray, mucoid, smooth, and semi-transparent colonies that on chocolate agar, but not blood agar. So it's probably chocolate agar can have factor 5 and 10. And then gram staining of the isolate revealed small pleomorphic gram-negative rods. So it's not staph, it's not strep. And Molotov was then utilized for definitive organism identification. Given these findings and the identification of this organism, vancomycin and acyclovir were discontinued, with the plan to continue ceftriaxone for 10 to 14 days. So after receiving antibiotics, she had no residual symptoms. All right, let's go to the discussion. So this was Haemophilus influenzae, which is a small, facultatively anaerobic, oxidase-positive, pleomorphic, gram-negative rod. Of the standard media used for bacterial isolation, like sheep blood, it grows only on chocolate agar, as it requires both factor 10 and 5 for growth. On solid media, colonies are large, slightly opaque, colorless to gray, round, and smooth. Haemophilus influenzae is broadly categorized in strains with a capsule, termed typable, and those without, termed non-typable. For this one, this was non-typable. There are 6 typable strains, serotype A through F, each with a unique capsule polysaccharide antigen. Each serotype can be detected serologically by agglutination using antisera specific to the unique polysaccharide antigen. What's prevalent is the the B serotype, and so there's the hip vaccine, and that has saved countless babies throughout the years because of this vaccine. Haemophilus influenzae can infect a variety of organs, and infection can be broadly categorized as invasive or non-invasive. Invasive infections are defined by tissue invasion beyond the mucosal surface and includes clinical syndromes like what we had seen with the woman: meningitis, epiglottitis, pneumonia, cellulitis, endocarditis, osteomyelitis, septic arthritis, and bacteremia. Invasive infections are associated with high mortality rates. Non-invasive infections include syndromes like acute otitis media, sinusitis, and conjunctivitis. Haemophilus influenzae type B is the most virulent strain, and when infection occurs, has the highest propensity to cause invasive disease. Haemophilus influenza type B, HIP, used to cause the vast majority of invasive infections. However, widespread vaccination using the polysaccharide conjugate vaccine has drastically reduced cases. As such, while rare, non-typable Haemophilus influenzae now cause the majority of invasive infections, delayed treatment or treatment failure may allow an initially non-invasive infection to progress to invasive disease, as in this case. All right, so treatment of Haemophilus influenzae, often empiric and beta-lactam antibiotics are usually used. Amoxicillin clavulanate is a common choice for non-invasive infections, while IV cephalosporins such as ceftriaxone are common choices for invasive infections. Of note, resistance to ampicillin, amoxicillin, and penicillin occurs relatively frequently now, usually due to the production of beta-lactamases. Across the U.S., approximately 25% of Haemophilus influenzae strains are beta-lactamase producing. All right, well, thank you for UPMC for this case, and I will see y'all later. Bye.